I know that many of you may be sort of sick of COVID, and that I'm well aware that CaTS investigators and Louisiana clinicians have done a lot of COVID-related research and outreach, particularly for testing and vaccines, and our virologists have also done quite amount of research. But today I'm going to talk about the impact of last year on all of us, but particularly on depression and anxiety. In a previous life, I was a clinical psychologist, and I've always been interested in the impact of stress, depression, and anxiety. So what a year it's been. In the last year, many of us experienced loss of health, of loved ones, income, graduations, proms. Families have missed holidays together, intergenerational contact and comfort. Kids have missed school, the structure, learning, friends. Parents have felt overwhelmed trying to connect their kids on Zoom. Many of us have felt hunkered down, stressed, isolated, vulnerable, COVID brain. Workers are pretty burned out on Zoom. Here you are on another one. And people are tired of TV. So what's the result of all the interactions and connections we've missed in the last year at work, with friends? Informal, random interactions on the streets, stores, going to movies, concerts, etc. Malaise, burnout, depression, and stress are up. I'm going to give some figures from a lot of different surveys. That one's from MetLife, who surveyed their employees. Harvard's Making Caring Common survey found that 36% of Americans reported serious loneliness last year. But look, another theme in this talk is the impact on young adults is much more profound. And it's ironic that it's the young adults who now are avoiding vaccines. Depression, anxiety, and substance use are up nationally. Adults reporting symptoms of anxiety and depression during COVID. The Kaiser Family Foundation has a tracking poll, and it just goes on continuously, and they track every poll out there. And so from January to June 2019, 11% of Americans said they had symptoms of anxiety or depression. But look, a year later, it was 41%, and a year later, it's 52%, but it's even higher among those with job loss. And in Louisiana, it is even higher still. Over 50% of people in Louisiana who lost their job report symptoms of anxiety and depression. Most common symptoms include difficulty sleeping, eating, increased use of alcohol and drugs, more prevalent among young adults, African Americans, Hispanics, and low-income population. The American Psychiatric Association DSM-4 criteria for diagnosis of clinical depression was 6.7% of the population in a given year pre-COVID. Then, same time last year, it was 16.6% in a lifetime. And these include feelings of sadness, loss of interest in activities. What is the deal with spelling? Lower energy, change in appetite, trouble sleeping, feeling worthless, guilty, difficulty concentrating. Anxiety is the most common mental disorder, and it affects 30% of the population. And this is characterized by excessive fear, anxiety, hindering our ability to function. So one of the points of this talk is that young people were more impacted. So there was a significantly greater report of depression and anxiety in the 18 to 24 age group. Anxiety was, in this poll, was assessed with the generalized anxiety disorder 2-question clinical screen. Over the last 2 weeks, how often have you been bothered by feeling anxious, nervous, or on edge? Or in the last 2 weeks, how often have you been bothered by not being able to control worry? This was scored on a 4-point Likert scale from not at all to nearly every day, and 3 was the cutoff. Depression was similarly assessed with a patient health questionnaire, a 2-item screen. Over the past 2 weeks, how often have you been bothered by the following problems: little interest or pleasure in doing things, feeling down, depressed, and lonely. Again, on a 4-point Likert scale. So this just shows you the impact on on income. And the lower your income, the more likely you are to have a major negative impact. But if you look at major and minor, it's not really that different. Over 50% said that the stress of COVID had an impact on their mental health. So minorities and young people experience disproportionately worse mental health outcomes. And this just shows you the odds ratio of anxiety, symptoms of trauma, increased substance abuse, and serious consideration of suicide. So it's more prevalent with Hispanics than whites, with Blacks than whites. Trauma was more prevalent with Hispanics and Blacks than whites. Substance abuse more prevalent with Hispanics and Blacks than whites, and serious consideration of suicide. And look at the age group. The odds ratios really crank up with the young, the very young versus the very old. And I think it's noteworthy that there's a 12 times greater consideration of suicide among the 18 to 24-year-olds than the people my age that are above 65. So bottom line, Hispanics, Blacks, and essential workers are 2 to 3 times at risk of increasing drug use and consideration of suicide. And young adults are at 9 times risk of increasing substance abuse and 12 times the risk of serious consideration of suicide. Drug use and deaths are up all over the country. In just about all U.S. jurisdictions, there was a report of increased synthetic drug use. And you can see with the bar graph, the months and how these synthetic drugs increased. In half of jurisdictions reported increases of over 50% in drug deaths. And last year, there were over 81,000 drug overdose in the United States. This was sad for me. Suicides are up in the medical community. Pre-COVID, 400 physicians and over 1,000 nurses were lost to suicide annually. But last year, over twice the number of doctors and almost 3 times the number of nurses committed suicide. And over 20% of doctors and 30% of nurses and allied health professionals seriously considered suicide. We here and every major CaTS institution is focused on research or clinical care of long haulers or symptoms of COVID lasting more than 6 weeks, and they're wide ranging symptoms. Most common include fatigue, anxiety, depression, cognitive dysfunction, dyspnea or labor breathing. And many of these individuals struggle to be heard and believed by their family, friends, or healthcare workers. It sounds like it's snakes in their head. Recent study found that a higher proportion of long haulers had pre-existing autoimmune disorders and pre-existing depression and anxiety compared to the general population. So Connie Arnold and I did a patient phone survey May through October, then we cranked up again in January. These results start April the 30th and end Halloween. And we surveyed over 500 patients, mostly female, 56% Black, 44% white. And in our patients up here, 45% live in small towns or rural areas. And in the early 2 phases of COVID, Blacks were more likely to know someone who had the virus, and everybody was more likely to know somebody in July through October than April through June. At that time, only about half had spoken to a healthcare provider about the virus. Now, at that time, visits were often telemedicine, Now, when I'm teaching medical students and residents, they are often asked about the vaccines that the patient initiates the question. And as of October, only 25% had been tested. Their knowledge was quite high, and this was all over TV. So they could name 3 symptoms of COVID and name 3 mitigation strategies. So how difficulty is it managing your health? Well, 33% said it was somewhat to very difficult managing their health during COVID. It's interesting that only 11% thought they'd get sick, but 79% thought it was a serious public health threat. You know, other people may get it, but not me. In the past week, how often have you felt nervous or stressed due to the virus? 20% said most or all of the time. Now, why is this so much lower than the earlier slides? I think it's because we cold called patients and just asked them that. And I don't know if they were hesitant to tell the caller or not. Most of those other surveys were online. How often have you felt alone or lonely because of the virus? Only 10% said most of the time. But look how this broke down by race, gender, and age. It's not really any difference in if they lived in the city or in a town or rural area. And this tells me that they were less likely to feel alone and lonely as the virus went on. I guess we figured out how to be, many figured out how to be resilient and accommodate to the new normal. What about nervous or stressed? It's about the same for Blacks and whites. Females were a lot more likely to report feeling nervous or stressed. So were older people, but the main group was 30 to 44-year-olds. My hunch is that the 30 to 44-year-olds were parents who were trying to juggle jobs, parenting, Zoom classes, etc. And people were more nervous and stressed in early phases of COVID. The PROMIS questions are what Connie and I use in research, not clinically. PROMIS stands for Patient Reported Outcomes Measurement Information System. It's an NIH initiative. It's easy to understand. It was validated with patients with low literacy, and it's good for research. So in the past 7 days, people are not good historians when you get to 2 weeks to a month to 3 months. I felt fearful. I felt anxious, felt worried, had a hard time focusing on anything, felt nervous, uneasy, and tense. Then there are PROMIS questions for quality of life, pain, for adolescents, for pediatric age group, for just about anything. But here's their depression ones. In the past 7 days, I felt worthless, helpless, depressed, hopeless, like a failure, unhappy, that I had nothing to look forward to, and nothing could cheer me up. That sounds depressing reading that. So here's some takeaways. Symptoms of depression, anxiety, trauma, and substance abuse increased during the pandemic. Clinically, we need to be mindful of this problem, especially with the young. We need to ask patients about symptoms, thoughts of suicide. Ask what they found that helped, what hurt. Consider telling them they're not alone. They're not crazy for having these feelings. Be aware of the impact of social determinants of health. Look at this. Poverty in Orleans is 32% for Blacks, but only 10% for whites. That's just about the same as Caddo Parish. 30% of people living in Louisiana are food insecure. So other social determinants of health are living conditions, safety of your neighborhood, quality of education, your ability to hold and keep a job. We need to offer support. Touch points are great, whether it's telemedicine, phone calls, or now increasingly visits. And if needed, people need referral for counseling, social service, further assessment. For research, I think we should move from measurement to intervention. We need to work with providers, patients, and community agencies to develop understandable, accessible, culturally appropriate education and feasible interventions and community-level prevention initiatives. We need to track progress and measure outcomes. And personally, we could offer small acts of kindness, find our sense of purpose, and think of all the things we're grateful for. So my last slide is, what's our bridge to action? What clinical research and personal practices could we implement to address depression, anxiety, and loneliness? Are we being mindful of health disparities and social determinants of health? Thank you.
Thank you so much, Dr. Davis. That was really memorable and moving, and might I say depressing. We are open to questions for Dr. Davis at this point. If you'd like to add a question to the chat box, I'll be happy to read it out to her. We're kind of a small enough group that if anyone would like to raise their hand and unmute themselves, we could let someone read, not read necessarily, but say their question aloud. Is there anyone who would like to unmute? Okay, looks like Dr. Fidel has a question. How are people doing with health literacy issues related to COVID?
I think there's a lot of confusion. People had a hard time with inconsistent messages. Apparently, we're finding that your doctor and your minister are trusted messengers, but people listen to their friends. And I think there's a lot of health literacy challenges and health numeracy challenges. What does the positivity rate mean? What do all these graphs mean? So there's a lot of COVID information, particularly in newspapers, that's literacy, health literacy and health numeracy connected.
Thank you, Dr. Davis. I had a quick question about your LSU patient phone survey. And so that's great that you were able to conduct it for about 6 months, you said, right? From April through October. Was it just in North Louisiana you were calling, and was it just cell phones? Like how do you do phone surveys now?
So here's the deal. We got the list for people that had registered for a telemedicine visit. And so from Epic, and we called them. And so it was just a cold call, but they were our patients up here. As the data showed, 45% were in rural or small towns, but they were all our patients. But yeah, it was North Louisiana.
Excellent. And it looks like a question has come in from Dr. Fort. He says, hi, Terry. To what extent do you think these problems are due to COVID versus any unknown disease pandemic versus non-pandemic natural disaster? For example, therefore, are there outcomes common to natural disaster, or is it something specific about this specific scenario?
I don't know. This is not health literacy is my area of expertise and not disasters. But I just think there was so much uncertainty with COVID, and you didn't know when it would end and if you would get sick or what you could do or not do. There was just so much uncertainty. And I think people just got hunkered down for a while.
You know, one of the things I would add, Terry, this is Connie, the difference with COVID compared to, say, natural disasters, we all seem to rally around and, you know, the natural disaster, and there's one theme and there's one message, and it's the community support and stuff. And you've really not, what you've seen is a very fractured message. So much more of a longer issue with this pandemic than what we would think, like when, granted, South Louisiana is still dealing with the hurricane. So there is a subset of group of people that the pain lingers, but I think for society as a whole, the message has been really fractured and people are very confused about who to listen to.
Connie, you say some things about the question about literacy and numeracy. What do you think the impact of the COVID message is there?
Yeah, I mean, I think, you know, I think that, as you stated, our numeracy rates are so much worse than our literacy rates. So when you start, and people love to spew statistics about COVID. And so I think that's one, very confusing. I think a lot of the stuff that initially came out and some of the stuff that has come out has not been literacy friendly. I mean, I think people think they simplify some of the language, but then they just put so many paragraphs on there about whether it's trying to answer a question. They get into the weeds, and I think you really lose the, especially people with low literacy, you lose the impact of the message. You know, I mean, you don't need to know every ingredient in the vaccine to answer a question about, is the vaccine safe? You know, I mean, too often we get, like as scientists, we get into all of the stuff and it just blurs the message.
Along those same lines, Dr. Fidel has a question on that I think both of you could probably chime in on. Do you think we need a large health literacy campaign related to the vaccine? And how do we do that?
I just think we need to have clear language about the vaccine and not jargon. All of us are so full of jargon, and it's hard to get things in a very clean way. We've got a handout that was developed at Emory in coordination with the CDC that's very literacy friendly, that I would be happy to share with anybody. It's the best that Connie and I have seen. The other thing I would say about the difference in natural disasters is, like with Katrina, the whole world was horrified by what happened, but offered support. And so they weren't impacted and were able to give to South Louisiana. Here, the whole world was impacted. Now, particularly India.
You're absolutely right. It's such a, yeah, what do you do when there are no onlookers? Everyone's impacted at the same time. Yeah. Any additional questions from our audience today? Thank you, Dr. Fidel, and thank you, Dr. Fort. We appreciate your questions greatly. And no one wants to unmute themselves. I want to make sure everyone has a chance if they're interested. All right. Well, then please thank me in thanking Dr. Davis, or excuse me, please join me in thanking Dr. Davis for her talk today. We really appreciate this additional spotlight on what COVID is literally doing to us still. Oh, and Dr. Fidel certainly wants your document. And so thank you all for joining us today. We appreciate it. I wanted to let you know that a recording of today's session will be available in the next 1 to 2 days. It will be shared via the LCATS listserv and posted to the LCATS YouTube channel. Our next LCATS COVID-19 Chronicle seminar will be held in 2 weeks on Thursday, May 20th, also at 4 p.m. Central. Please join us then for talks presented by Dr. Candace Myers from Pennington, and from Dr. Suzanne Tinsley from LSU-Shreveport. We welcome more speakers for this seminar series. So if anyone in this audience would like to be a speaker, or if you know of anyone at your institution who would like to be a speaker, we would love to hear from them. Anything that would appropriately put COVID in the title of their talk is something we want to know about. So please feel free to reach out to us at the email address info@lcats.org. Recommend yourself, recommend a colleague. We appreciate it. So again, thanks so much, Dr. Davis and Dr. Arnold. Thank you also for being here and speaking up. We appreciate all that you both do so much for LCATS and for all of Louisiana and the US. So, all right, take care, everybody.
Bye.
You're welcome.